Hi, everyone. Thank you for joining us at Stories of Care, a podcast about infection prevention and control and healthcare equity. I'm so excited to be talking to you all today about hospital-acquired infections. And for that, we have a special guest with us today. Pat, thank you so much for joining us.
I'm excited to be here, Megan.
So you have had a wealth of experience. Can you tell us a little bit about your story and how you've ended up where you are today?
So I have been in healthcare. I'm a nurse. Most of my clinical experience has been in critical care. And I've done various roles over my 44 years, from, at the bedside to up the administrative, unit manager, nursing director, and then moved into quality positions and after operations, and have been in quality probably for the last 25 years. And have done a lot of work in, since the patient safety movement, after the To Err Is Human was published, right? And in the state of Michigan, where I've done most of my practice, I spent 15 years in Southern California and San Diego in the SHARP system, SHARP Healthcare. And then moved back to Michigan, my hometown, and did in 2003, the Michigan Hospital Association wrote to AHRQ and got a grant. And their focus was to improve safety and reduce errors in the ICUs. And that's called the Michigan Keystone ICU Project. And so Johns Hopkins was Dr. Peter Pronovost and his team from the Johns Hopkins Quality Institute came and consulted with the state of Michigan, and we worked on decreasing, and our focus was infections in the ICU, and then also culture of safety. And so we focused first on CLABSIs and got that to where the median CLABSI rate in the ICUs in the state of Michigan was 0.
Wow.
And so and we had publications in 2006, and then a follow-up again in 2009. So, and then from that work, continued working with AHRQ as well as Johns Hopkins in a consulting fashion, and along with my day job, to model that across the country. And the pay for performance focus, and it was modeled after a lot that was done in the state of Michigan, where the state hospital associations took the lead and assisted the hospital.
You mentioned something that I don't know how many of our listeners might be as familiar with. You talked about To Err Is Human. Tell us a little bit more about that.
Well, so that was a book that was published in 1999, right? And it was the first time that it was brought up that medical errors are the third leading cause of death for hospitalized patients. And so it really brought it to the forefront. And there's been a variety of books, Crossing the Quality Chasm and others, but that was kind of the launch of the patient safety movement to say, we got to do something different. And we know that by standardizing processes, you can help prevent errors, but also you have to have a focus on culture, right? So culture is so important. People have to feel comfortable speaking up. They have to feel comfortable knowing what they're doing is the right thing. And if they see something that doesn't seem right, to be able to escalate that or elevate that, so to keep harm from happening.
Well, to me, it really was a hallmark of, as you're talking about culture, that time when the perfectionism of healthcare and the perfectionism of medicine started to embrace, we can't always just blame people. It's more about trying to do this in a positive light, especially so that way we can catch it before it actually causes a horrible mistake.
Right, because what we know, and Lucian Leap and the IHI and all the other safety leaders, shared with us that really those errors are the result of failed processes or lack of uh, um, system processes and system support. And they're not the fault of the person because the person is working within this faulty system.
And when I was going through medical school, it was about a decade after this had been published is when I started medical school. But it was still, even then, I mean, and even today, what,
Oh, it is
two
even
and a half
today.
decades?
Yep.
It's hugely entrenched. But because that movement had started at least a decade beforehand, we were starting to have those conversations about how anyone can spot and anyone should speak up. And sure, of course, there always are concerns because that culture is so entrenched, but it really was that the beginning of that idea that it should be a whole team approach rather than just the person at the top makes the calls and it works on down.
Yep. And really that each member of the team has similar value and
Mm-hmm.
equal value, right?
Yeah.
And so that decisions are joint decisions with the input of the whole team.
Yes, yes. And let's be honest. I mean, everybody on the team has different exposures to patients. The dietitian does certain things. The EVS, environmental services, does certain things. The physician, the nurse, and so we all have a different perspective. And being
Yep.
able to say, "Oh, I saw this because I did this specific procedure or part of their care," something that maybe the physician wouldn't have seen or the dietitian wouldn't have seen. It's so important to be able to bring that to the table because it can completely alter somebody's outcome in a positive way.
Absolutely. And that's where the culture is so important, that you need to have that culture that supports the input of everyone, that everyone's input is equally valued and listened to, right?
Yeah,
Um, and and that's how you keep our patients safe. That's a key component to preventing hospital-acquired infections.
it is. It is. And honestly, exactly what you're talking about, the people that you worked with really, I went to residency at Hopkins. And so they really kind of brought that same thought process there. So from the very first moment that I started residency, it was a rule. You never do rounds unless it's multi-D rounds. There's always
That's right.
multi-D rounds. It's so
Yep.
important. And I just can't imagine functioning in a world where that didn't happen. So that brings me specifically when we're thinking about different ways that each portion of the team can contribute. When it comes to HAIs, we know that there is this solution that helps to bring down the rate of HAIs, nurse-driven protocols. Can you tell me what exactly are nurse-driven protocols? Explain it to us.
So nurse-driven protocols are when nurses are given the autonomy or the permission, right, to make certain decisions in without having to call a physician for an order or an advanced practice provider. So there are many examples, right? So in the ICU where I did most of my practice and still do a lot of quality work in ICUs. ICU sedation is common, right? Continuous sedation. And so there are nurse-driven protocols to titrate sedation to achieve a certain target, right? So that's a protocol. Heparin drips or insulin drips, right? There are protocols that allow the nurse to, based on what the lab value is or the blood sugar or the PTT, to be able to dose the and change the drip rate. For infection prevention, one protocol that's available and people use is nurse-driven urinary catheter removal protocol. And that becomes very important because we know you can't get a device-related infection if you don't have the device in, right?
Mm-hmm.
So decreasing device days, either urinary catheter, central lines, other lines and tubes, are important to prevent those infections from happening. And so a nurse-driven removal protocol allows the nurse, when certain criteria is met, to, when the patient no longer meets the criteria to have a urinary catheter, they can automatically remove it without having to call anyone to get permission. That's part of the protocol, that if you don't meet this criteria any longer, then you can remove the catheter, and there's instructions on how to do that and how to follow up after the removal. But that allows that decision to be made anytime during the day, rather than on rounds where you have a discussion. Do we still need this catheter? Well, maybe we do then, but later on in the day, it's no longer needed, and
Yep.
you no longer meet the criteria. Now I don't have to wait till tomorrow morning when rounds happen again to have that conversation, or I don't have to call anyone. The nurse can then just remove it.
Yeah, I mean, it's better for the patient care. It's better for, honestly, it makes the job a little bit easier also for all people involved in their care, not having to worry about this additional line. And the comfort of the patient, too, just being able to do that when it's 12 hours earlier, 13 hours earlier, such a difference.
Well, and we know that the urinary catheter besides potential for causing a urinary tract infection, has other potential, right?
Yep.
It's a 1-point restraint, right? So
Mhm.
it's holding them to the bed. They're not getting up and mobile, or when they get immobile, they are an increased fall risk, because now they're tethered to this thing that they might trip over, right? So and we know the importance of mobility, right?
Yeah.
To keep that patient active, and so that they don't lose any function during their hospital stay. Also, it's because they're tethered to the bed with this and less likely to get up, increased chance of developing delirium as
Yeah.
well. So there's a whole host of other things that are unintended consequences from having that urinary catheter in place. So getting it
Mhm.
out is the best thing we can do.
Definitely. And hey, the longer or the shorter we can make device days, the better it is for everybody in the long
Yeah.
run. So tell me, how exactly are these protocols established?
Well, so you do want to follow a process, and they're
Mhm.
just like any time you want to put in a new evidence-based practice, or you find a problem and you want to solve it, you should be following a standard way of doing that. And so typically, so for example, with putting in a urinary catheter uh, removal protocol, you might start off with, gosh, our catheter device days are too high, right?
Mhm.
And so let's look at the literature and see what's available for us in best practices to reduce that, right? So you review the literature, you decide, oh, one of the things that we're not doing to help decrease CAUTIs or decrease infections or remove or improve device days is we don't have a nurse-driven protocol in place. And so then you would put a team together, and maybe you already have an existing team or a committee that deals with hospital-acquired infections or on your particular unit. And that committee should be multidisciplinary and should have some physician champions and experts. And when you're talking about the urinary catheter removal protocol, you probably want to have urology there, right?
Yeah.
Because they're experts. So you have nursing experts, you have physician experts, any other people that are, use an established committee, or you put together a group, and then that group looks to get buy-in from who are the stakeholders in this problem
Yep.
and this solution. Who do we work with? Who do we need to work with to get buy-in? Talking with them, seeing what their concerns are, what their issues might be. And then the
Mhm.
team puts together a protocol. How do you want it to look, right? And this is where your experts will help. And then you want to say, okay, how do I put this then into the workflow, right? Into
Mhm.
the workflow of the nurse and the physician, right? So how do I capitalize on the EHR
Mhm.
as well? And then you're going to provide education, you're going to make all those changes necessary, then provide education, and then you're always going to follow up with, okay, did it work?
Yep.
After what data do I need to collect to see if this new process worked? How do I tweak it? So how do I do PDSA? How do I do Plan, Do, Study, Act on this particular intervention that we've just done?
And from my experiences being in the hospital, it seems that we usually try to start these in one unit and then slowly spread out, never, regardless whether it's nurse protocols, whatever the change is, whatever the big change is, so that way we can see, did it work well there? Okay, great. What can we change to make it more adoptable or
Yep.
easy or more successful, and then kind of roll it out larger, especially because there's so much education that's required.
Yeah, and so yes, now your committee might involve many more people, right?
Mm-hmm.
And many more units, but then you choose to pilot it, right,
Exactly.
in a few units to work out the bugs, to check, test the flow. Does it work? What are the issues? So that when you're making those changes, you're not having to make them house wide. You can do those tweaks, but you need to make sure you have a pretty good representative sample when you're piloting it. So a medical unit as well as a surgical unit and an ICU, right? So that you're able to get a good idea of how it might work in those areas. So absolutely.
And I gotta say, brilliant use of an unintended pun there, working out the bugs as we talk
Yeah.
about infection. I'm from Iowa, so I'm very corny. Love those.
And
Well, that's
probably one of the key things, especially with nurse-driven protocols, is the physician support, right? So understanding their point of view related to it, getting their support, and any nurse-driven protocol of any kind needs to get medical staff approval, right? So if it's things that it's really something then delegated, right, to a decision that would typically be made by a physician or advanced practice provider is now delegated to the nurse. That protocol has to go through that medical staff approval process, and to have that policy
yeah.
be supported. So that's an important piece.
Mm-hmm. And especially because each patient is so different, then that revisiting those protocols on multi-D rounds is so important too.
Yep.
Yeah. And when it comes to partnering, like you're talking about, and that critical piece of really needing to communicate with one another, what is the best way that nurses and physicians can partner on efforts like this?
Well, so starting off at the development stage, right? So being a part of that committee, being a part of that group that is doing the work is key, right?
Mm-hmm.
And then having when you put things like this in place, it's really important to have physician champion, a nurse champion in that particular area that will kind of carry it along, right? And be that person to, if you have a fallout or if you have an issue and it's related to a physician, the physician champion can talk to that person. Same with having nurse champions. Then you're talking discipline to discipline, but you're working together, right? So you're
Yes.
on that team working together. So that's one of the places you're connecting, especially to put in protocols to decrease infections and device stays. Also, you talked about earlier, Megan, the importance of interdisciplinary rounds, right? For patient safety in general, right? So to have good communication, and it's tough in different areas in the hospital to hold interdisciplinary rounds, especially if you're in if you're in a closed ICU, right? So you have a set of providers, et cetera. It's easier, but even there's pushback and opportunity. But on the non-ICU areas, when you have multiple different services rounding on units, coordinating that is
Very
very
cool.
difficult. It's a challenge, but it's also important, even if the rounds just has the physician and the bedside nurse.
Mm-hmm.
That's multidisciplinary, and you
Yes.
got good communication going between the group. We've done in a variety of places that I've worked, ensured that we had good multidisciplinary rounds in the ICU, and really created standard work. So had
Mhm.
scripts on what the intern or resident would
Mhm.
what their role was, the fellow, or the attending if you're in a community hospital and you don't have the trainees
Mhm.
there, and what the nurse would say, and what the respiratory therapist would say, what the dietitian would say, so that it was when you create standard work and you
Yeah.
do it the same way all the time, then you're going to get the outcome that you desire.
Yeah.
And it's important to have the nurse play a significant role in those. Every voice is important, but the nurse is the one at the bedside 24/7. And so having their voice. And so typically in institutions that I've worked in and then consulted with around the country, those interdisciplinary rounds, it's the nurse that's talking about the urinary catheter and
Mhm.
asking the question, do we still need this? And you have to go beyond, do we still need this? If the answer yes is not good enough, why do
Why?
we still need this, right?
Why?
And is in critical care, we are challenged with, well, they're in the ICU, they need a catheter. Well, that's old thinking, right? And
Yeah.
we know that the indication in the ICU is for patients that you want to accurately record their INO. But
Mhm.
we have a lot of other ways to be able to do that. And unless you're going to really respond hourly or every couple
Mhm.
hours to that urine output, you could use another means. And so having that conversation at during rounds to, okay, why do we still need this?
Mhm.
Well, the just in case is the benefit doesn't outweigh the risk of keeping it in.
It's so important
Yeah.
and so valued. So, if you had to leave our audience with one major takeaway from all of this and all of your experiences doing this at the bedside as well as an administrative side, what is the major takeaway you want people to know?
Well, collaboration and working together with all members of the healthcare team to make it safer for our patients, right? And so it's that communication, it's that collaboration, and that you need to also have standardized processes, right? So, and make sure that people are aware of what they are and have them make it easy to do the right thing, and more difficult to do the wrong thing. But then back to what we first talked about also is the importance of culture, right? So creating that culture that people realize that every member of the team adds value and should be able to comfortably speak up when they have a concern, question, or they just want to give their input. And that's how we make our patients safer and our hospital safer.
Stories of Care is a publication of the AMA and CDC's Project First Line. Project First Line is a national infection control training collaborative working to provide all healthcare professionals with the foundational infection control knowledge they need and deserve to protect themselves, their patients, their coworkers, and their communities. For more information, trainings, and other infection control resources, visit cdc.gov/projectfirstline and amafirstline.org.